Hello and welcome to Paramedicine.com.
Translating research into practice.
I'm Mark Colbeck at the ACU Sound Recording Studio in Brisbane, Australia.
And I'm Sonia Maria, and I'm at Charles Sturt University campus in New South Wales, Australia.
And this is episode 3, the secondary survey.
Okay, well, if you were listening in last week, you would have heard us talking about the primary survey. This podcast is about the secondary survey. The two together are actually reflected in our article that both Mark and I put out, which is published in the Irish Journal of Paramedicine. That was an article that we did as a Delphi study with a whole group of other people, looking at the best evidence and also about the way that we actually complete the primary and secondary survey as paramedics. So this podcast today is specifically about the secondary survey, and it's broken into multiple little parts, of which Mark's going to tell us about. So Mark, handing over to you.
Okay, so when we did the primary survey, we started with the safety first, get A, B, C, D, E's. And this survey, the secondary survey, has a similar sort of initialism to guide it. So the initialism that we use is actually a statement which stands on its own, just like in the primary survey. And the statement is, I had vital signs assessed and treated. And this actually came out of me years ago in the 80s, 90s, when I was working as a paramedic. I used to sit in the back of the ambulance and think, as you're filling out your form and the patient's stable and you're just getting ready for the handover to the hospital, and you think to yourself, have I done everything? And I needed a way to summarize everything. Like, what do you mean by everything? And so I came up with the statement. I see that I had the history, allergies, and I see that I had vitals assessed and treated. Yeah. But then I broke each one down, and I'll give a quick summary of what each one means, just so that the listeners have a guide map of what we're talking about. And then we'll go through them in detail. So the ICI, the first I is identify the patient. The C is chief complaint. The second I is the incident history. And then HAD, H-A-D, is their history, their past medical history, their allergies and their drugs. And then vitals are the vital signs. Assessment is the physical assessment that we do of the patient. And then treatment, or treated, is the summary of the treatment they did and the summary of the treatment we did and its effects. So I had vital signs assessed and treated. Identify, chief complaint, incident history, past medical history, allergies, drugs, vitals, physical assessment, and treatment. And it all just comes together really beautifully and works like an overarching table of contents for the rest of the call. If the primary survey is the first minute or two, well, sometimes it's all we get to, like in a cardiac arrest. But in most calls with a conscious patient, it's the first minute. The rest of the call is I had vitals assessed and treated. So why don't we dive in a little bit and start talking about what each of those factors are? Do you want to start with the first one then, Sonia?
Yeah, sounds good. Okay. All right, let's talk about the I, and the I being for identify. Now, at a cardiac arrest, obviously, you might not be able to get a lot of this information, but you might be able to get it from the people who are the family or the nearby people or the carers and the workers in the nursing homes, etc. So this information, some of it may be easy to get, and some of it you might have to, work around the edges until you find out a little bit more about what's going on. So identify is pretty simple. It's the name of the person, their age, their date of birth, their address. If this is where they live, then, if you're going to a call of the house, not always the person lives at that address, so don't get caught out on that one. Mm-hmm. If they've got a healthcare card, this could be a good time, when you're getting this information. One of the things I used to like to do on the road is if the wife or a family member was standing around sort of twiddling their thumbs a bit, I would ask them would you mind writing down their name, the date of birth, gathering their Medicare card, their healthcare card, and getting all those little bits and pieces of identity together for the patient. And quite often that would help me with this little part, so I didn't have to write it all down. I actually got them doing something, and they felt useful too. So identify.
Did you ever get to the hospital and realize I can't read any of their writing? I don't know who I just cared for because I was relying on them.
Or the other one that I find with elderly people is that they often call themselves by their middle name, or
right, yeah.
so they might be a Lorraine, but really their name is May.
Right.
So, you'll find on their identity cards and their healthcare information, sometimes their name is different to what they say it is, especially with the older people.
Yeah.
Okay, Mark.
So
Sorry.
just before I jump, no, that's okay. Just before I jump to chief complaint, there's another thing about the identifying the patient. I've got a friend who I teach with here who is a trauma nurse. And one of the things he says is the best thing you can do for us is give us the patient's full identity before you arrive. And I used to work with a physician in the Emergent. I remember him saying, I'd rather have a chart than a stethoscope, because it's kind of like a cheat sheet. You can read everything in the past about the patient. So identifying the patient is obviously important for our paperwork and all that sort of stuff. Really on a call, as long as I know their first name, that's good enough for me. But in the hospital, they're going to want this information. And if we're doing an updating with the full information so that they can pull a chart before they get there is immensely helpful in the Emerge.
Yeah, absolutely.
Yeah,
if you get that opportunity to do that handover before you arrive at the hospital, it's like gold for them.
Yeah. So the next thing is, so we did I, identify, C, which is chief complaint. And when we say chief complaint, it's a bit of a short form because it's chief complaint or it's the chief condition. So what's the difference between those? Well, sometimes people will tell you, I've got a headache or I've got a sore stomach, but it's rare that you show up and someone's convulsing and they stop and they say, I'm having a seizure or I'm dead. They don't complain about being dead. That's a condition. It's something that we actually discover for ourselves that's not reported. So they're not complaining about it. So we have this chief complaint or condition. And when we say chief complaint, we mean complaint or condition. And it's the answer to the question, what's wrong, really? So usually in a conscious patient, I say something fairly open, like, hi, my name's Mark. I'm a paramedic. How are you? And just leave it at that. Or how can we help you if they kind of waffle around? So how can we help you today? What did you call us for? What can we do for you? Something like that. And I find it's a really good, I want to say trick, but it's not a trick. It's a valuable technique to then just shut up. Like give them a minute or two, let them frame it however they want, recognizing that they might have been. Yeah, they might have been. Although even with that practice, they're not a medical professional and they're not used to doing a handover. So for us, it's going to feel kind of all over the place. And when I've done it, when I've seen other paramedics done it and rush them and interrupt people and say, yeah, but what's wrong? It kind of cuts the rapport, that giving them a minute or two to just say what they need to say, because all this anxiety has been building up. They've heard the sirens coming. The people walk in. Now it's your turn. Now you tell me, how can I help you? And I'm just going to shut up and you tell me. And then we take a little while. So give them, the open-ended question. So how can I help? What seems to be the problem? And then when they've gone through what they need to say to you, there will come a pause. And then you can start to ask more focused, precise questions. So you say it's difficult for you to catch your breath and your chest is uncomfortable and you've been a little bit dizzy. Which one of those came first? Which one of those seems to be the biggest problem for you right now? What would you like us to address? That sort of a thing. And when I think about asking about a chief complaint, I usually think of several systems, and I kind of do this from head to toe. I think about their brain, I think about their lymph nodes, I think about their heart, their lungs, and their kidneys. And what I'm thinking as I do that is, with the brain, I think, so do you have any altered mental status? Have you been dizzy? Have you been lightheaded? Has there been any presyncope? Do you have any vertigo? Like those are the questions I ask about. And in a very broad sense, that tells me something's wrong with their brain. They might not have enough sugar. They might not have enough oxygen. I don't know, but it may be a CNS condition, but I want to know if their brain is okay. From the brain, I go down to the lymph nodes, and the lymph nodes remind me to ask, have you had any infections lately? Have you had a cold, a flu, or a fever? Have you been coughing up green eggs and ham? Does it hurt when you pee? That sort of stuff. Just quick, infectious type questions. And then the heart. And for me, I wrote an article on this, and there's a lot of myths about chest pain, especially in acute coronary syndrome. So I have a bit of a catch-all phrase. I say, Do you have any pain or discomfort in your head, your neck, your belly, your back, your arms, or your legs? And if they say anything vaguely like, oh, in my chest I've got, then that's good enough to start me thinking about acute coronary syndrome. Anything above the belt, you got to start thinking about acute coronary syndrome. If they've got a complaint above the belt, they get a 12 lead. And then lungs, I ask, how's your breathing? Are you breathing okay? Have you had any difficulty with that? And that's a good enough, broad enough question to get me a lung picture. It's my paramedic lung scan. And then the kidneys are basically perfusion. And I ask them, have you been drinking normally? Have you been peeing normally? My cap refill will give me a bit of an idea about that. Their JVD, when I look, how full is the tank? That's kind of what I want to know. And if I'm worrying about like a congestive heart failure patient, have your shoes been getting tighter? Has your belt been getting tighter? Has your belly been getting bigger? Have you put on weight? Have you lost weight? Those are sort of my quick, immediate questions of how's your brain? How's your infection? How's your heart? How's your lungs? How's your perfusion? And those are usually the 5 big things that I find chief complaints spring from. They'll fall in one of those camps, usually. Or they might say, my leg's broken. And that's, the trauma tends to be fairly obvious. And when they tell me that something is wrong and I get the list, then I want to prioritize the list. And it's which came first, which is worst. So for example, if someone says, I got crushing midsternal chest pain radiating to my left arm and jaw, and then I found it really difficult to breathe, I'm thinking, okay, cardiac, poor perfusion, interfered with their oxygen delivery. Or if they say, I'm an asthmatic and I just couldn't breathe, and or I've got anaphylaxis and, my airway started closing and then I started getting dizzy. It's like, okay, so that's probably airway problems leading to cerebral hypoxia. Let's focus on the airway, not whether or not you're having a stroke. So
that makes sense.
So that's chief complaint. We identify the patient, we do the chief complaint, and then when we figure out what it is we want to focus on, then we have a broad set of questions that we can ask about. And I'll leave that over to you with the incident history.
Correct, yeah. So that's right. So once you've sort of narrowed it down to what you're thinking that you need to explore, these are the lead-in questions or the things you need to start thinking about the incident itself. And you'll be familiar probably already with OPQRST or PQRST when I learnt it. So what we've done here is we've added an N onto the front and a U onto the back. So it's basically NOPQRSTU, all right? So the N stands for normal. When did they last feel normal, and what is normal for them? So this is where you need to explore the normal for them. So if it was a chest pain or something that they would get, that they're familiar with, breathlessness, chest pain, any kinds of pains, are these similar to what they've had previously, which may or may not have been a known condition, may or may not have been previously looked at, but, what is normal for them? And it could be a COPD patient, is this breathlessness normal for them? So you may already have something wrong with the patient, which is in addition to something that is abnormal, but is a normal for them. You know what I mean? So they could have a sickness on top of something that already could be considered abnormal for somebody else.
The acute on chronic condition.
Yeah, that's a really way of explaining it. Yeah. So the second thing is the onset. So O is the onset of the situation. So the time and also how fast it came on, and if they are aware of anything possibly that might have set it off. So for people who have known difficulty in breathing, so asthmatics or anaphylaxis, COPDs, even chest pain, they usually do know that there's things that precipitate it, which is the next one, but there's the onset, they explore that onset time about how quickly something came on or how slow it was. Sometimes you'll find that it might have been leading up over the last week, especially with infections or somebody else in the family might be also sick. So explore that onset itself. Now, P is the provocation, or what is provoking it, or what is palliative for it. So when we talk about provocative factors, is there things that make it feel worse or better? So if we were looking at a pericarditis patient, you might find that positioning or they get relief, or positioning may help the situation and make them feel better. So is it palliative in the sense that they may have a condition that is a known condition and that they have factors that might make it feel better? So they might take 2 Panadol, 2 sprays of GTN. They might have a situation where there are known things that make it actually feel better or feel worse.
Mm-hmm.
So the P is about the provocation and the palliative type of, sensations that we get from being unwell. Q is the quality of the pain or the sensation of the feeling. So it may be a pain, but they might describe it as something else too. So it could be pain and sharp, dull. It might actually be a sensation of dizziness or breathlessness. So what is the quality? Get them to explain it in their own words about the quality of what they're feeling. We know that this is important because, visceral pain, somatic pain, people explain them to us in different ways, and it's quite often in their language, or even if they point or if they move their hand in a general sense. Yeah. You get a lot of that, the concept of quality, just by whether people are sort of specifying pinpoint pain or using a general fingers open in the way that they're explaining it, or sharp and dull, etc. Okay, so the radiation. Radiation is always a really interesting one, isn't it? Because nerves, can often refer pain to other parts of the body that have nothing to do with the actual area that is of problem. So, especially atypical patients.
Yeah.
You might get a toothache, that's actually a cardiac pain, or you might have Kerr's sign, which is the pinpoint shoulder pain from something going on with, blood in the diaphragm or blood in the peritoneal cavity. So you can get all kinds of referred type pains, and I think it's really good for us to actually understand where pain can be referred to. So that could be a good lesson another time, Marcus, maybe talking about types of referred pain.
Yeah, that's a good one. Or like knife-like pain through the shoulder blades. You start thinking aorta. Yeah. There's all those little tips.
The wording, tearing sensation.
Yeah.
Ripping, tearing, dull, sharp.
Yeah. It's funny too, because I know when students are memorizing this at first, sometimes they'll try to force this onto everything, and they'll have a short of breath patient, and they'll say, "Can you tell me about the quality of the shortness of breath?" And the patient's like, "No." So, no. I don't know what you mean. So sometimes we don't use all of these, quality is one that we might skip if it's not relevant.
True, but also the quality. When you think about it may be too, though, because when you're talking about the types of shortness of breath, it may be worse to take a breath in than it is to actually breathe out, because it might be involving intercostal muscles or muscular type thoracic pain. So that could be something in there, as like when you're thinking about the details of the types of shortness of breath, it was traumatic or pneumonia. Or, it really does help to differentiate the different types of things.
But that would be provocative and palliative.
It would, yeah.
I'm being pedantic, but you're right. I mean, the idea is with all of this is not to be too precise, but to have a tool to get as much information in as you can. So
that's right. These are all your cues, aren't they? These are all the things that you're thinking that, what's making it worse, what's making it better. S is for severity. So severity of the complaint, may be pain or the condition that they're experiencing. So whatever that is. Mm-hmm. And if we were talking about pain, we would quite generally, most of us use a 0 to 10 scale, 0 being no pain, 10 being the most pain that we can imagine or that the patient can imagine, because remember, that's a subjective description from the patient, not our subjectively, sort of working out whether they're in pain or not. It's what they tell us, and we base our pain management upon what they're telling us too. And if it was something like breathing, like a breathing problem, then we could use things like mild, moderate, severe, which is especially good when we're talking about things like asthma, because, we base a lot of our treatments into those categories about whether we're nebulizing or going straight for things like adrenaline. So depending on the severity of the circumstance, we would try and get a scale of some sort that we could then work with. You might find also that with elderly patients or children, that you might use something like a visual analog scale. So the Wong Baker faces, the smiley happy faces, or with elderly patients or patients who can't communicate, you could use a FLAC scale, which is looking at their face, their legs, arms, and whether they're grimacing and facial expressions and things like that, which is great for people who are disabled, who can't communicate. Mm-hmm. Okay, T, moving on. T is for typical. So is it typical for this patient? And a good example, it could be a patient who has a long history of some kind of chronic problem, so epilepsy, diabetes, Alzheimer's, whether that is it's a new episode or something different. So this is again what you're talking about, the acute on chronic presentations. But not only that, I also think typical to me is this a typical presentation of what I'm thinking it could be, or is it potentially atypical chest pain or atypical something else? So T for typical, and also was there any again for T is trauma. Was there any precipitating trauma that might have started it off? And it could have been something physical like a blow or a car accident causing an injury, but it might also be something like a history of a week of coughing, that has caused some kind of damage in the lungs. You know what it's like.
Because that's sore.
It's really sore. And then we get cold to a chest pain, but, really they've just got, pleuritic pain or diaphragmatic pain from coughing for so long. So, T could be trauma, or it could be, typicality for the patient. Now, the last one is undigested food, which is a really interesting one. And Mark and I had a little bit of chat about this because I had to take my dog into the vet this morning to get a dental done. And, of course, they say, make sure they don't eat, for 12 hours beforehand, because it's an anaesthetic risk,
Right.
And, for us, we worried about eating and drinking because of, loss of airway control or difficulties managing the airway potentially. But in saying that, Mark, you also said that there was a bit of research there that's now showing that we don't probably really need to do that. Is that right?
I think we used to worry about it a lot more as paramedics before we could do RSI, the rapid sequence intubation, before we could paralyze the voluntary muscles of patients. Because if you're sticking a big tube down their throat, there's a good chance they're going to throw up. I mean, I probably would. But if we've sedated and so they're unconscious and we paralyze them so they can't move, then they're not going to throw up, and it's less of a risk factor for us. And at the end of the day, if you've got to secure the airway, then you've got to. And then if they do throw up, unfortunately, then, we tilt them and we do pulmonary toiletry and we clean out their airway, and then we try to get the airway again. But like if you're going to the drastic steps of we really do have to secure this airway, then you really do,
Yeah. Okay, so you being undigested food. Okay, so that's our last sort of part, and that ties off that little package of the incidence history.
Right.
And the next thing we're going to move on to is the actual normal history for the person. So what we were just doing was the incident history, and the next part is the actual just person's history, and that's over to you, Mark.
Right. Okay, so we've identified the patient, we've got their chief complaint or condition. We've talked about the incident history of that complaint or condition using the NOPQRSTU, and now we're going to do their personal history, past medical history. And when we think about the history, there's a few sort of ideas to keep in mind as we approach this. And the first idea is we go from a very wide, open-ended type of question to a more narrow type of question. So the first question usually is, do you have any medical problems? And people might say yes or no. And if they say yes, we can pursue it a little bit more. If they say no, then we can ask, so no diabetes, no epilepsy, no problems with your heart, no problems with your lungs, and we're getting more and more narrow. So that's one sort of overall schema to keep in mind, is we're going from wide to narrow. And the other one is that when we ask about the history, we ask, there's you, there's your family, and then there's your life, which gets into more of the more socioeconomic history. So when we start off and we ask the person about their medical history, we ask, like I said, any problems with your heart, your lungs, diabetes, or epilepsy? Like I've said that so many times now that's just my standard phrase. So you can come up with a phrase like that. And they might say to you, oh yeah, I have some angina. My question at that point is, I don't want to dive into the angina yet. So I ask, okay, you have angina. Is there anything else? And they say, yeah, I have angina. A few years ago, I had cancer. Okay, angina and cancer. Is there anything else? And I get the list. And if they had, a torted testicle 60 years ago, that's usually not an issue for me. But I want to get the list of all, hopefully not, get the list of all the things that are a problem, and then I can start to prioritize them in my mind. And the other thing that I find is that you really need to ask the question, is there anything else, until they're saying no. And I always catch my students with this because they'll come in and say, do you have any medical problems? Oh, I have diabetes. Oh, what type of diabetes? Type 1. And do you take insulin?
Off on a tangent.
And then off they go and they're lost. And if I have a student do that, then I always make up more medical history that they didn't get. So you keep on asking, what medical history do you have? Anything else, anything else, anything else, to the point of exhaustion, to the point of them saying, no, that's it. And then you can start to prioritize. And keep in mind that sometimes people will have a medical history, but they don't really consider it a medical history. The number of times I've said to a patient, do you have any medical history? No. Do you take any drugs? Yeah, I take angina, or I take nitroglycerin, or I take insulin. It's like, oh, okay, let's back up. So what are we taking the insulin for? Diabetes. Okay, so that's medical history. And I don't chastise the patient for saying, that's your medical history, don't you know? I just, okay. And I use that as an education moment saying, if a healthcare provider asks you if you have medical history, that's an important headline to put up front, because diabetes has a lot of issues. Or if you're having chest pain and you've had angina before, that's really important for us to know. And I try to educate like that. So, do you have any problems? No. Problems with your heart, lungs, diabetes, epilepsy? A little bit of problems with my breathing. Okay, anything else? A little bit of problems with this. Anything else? A little bit of problem with that. Okay, let's prioritize. And now I'm going to start asking about that history. If they've got angina, what's the angina typically present like? If they've had cancer, where? Has it been treated fully? Are they in remission, or have they been, declared free of cancer? Get the details. And as we go through further podcasts, so for example, when we talk about someone says, I have asthma, well, then we're going to be asking questions like, how bad is it? What are the drugs you're taking? Are you on steroids or just Ventolin? Have you ever been intubated? Have you ever been admitted? Like, there'll be more questions to ask. But for now, we're just trying to get that broad picture. And if you can, after we've got a little bit about their medical history, then it's good to ask, who is your medical provider? Who's your doctor? Do you see a alternative healthcare provider? Do you see a naturopath or a chiropractor or anybody else? Let's get those people's names, because they can maybe give us a little bit of medical history later on down in the patient care journey. So the emerge department might want to call up the family doc if they have the opportunity and say, what drugs is this patient on? They seem to have a whole bag of them. Which are these current? That sort of stuff. So that's the history. We're talking about the past medical history. We're talking about the history of the patient. Now we want to ask about the history of the family. How do they fit into their family? Because there are conditions like cardiac problems, brigadas, or something like that, that if they exist in the family, there's a good chance that they exist in your patient, like malignant hyperthermia or something like that. If your relatives have that, then I need to be suspicious of that in you as well. So we ask, are you part of your family genetically speaking? So are your parents your genetic parents, or were you adopted? Are your brothers and sisters your genetic brother kin, or were you adopted? And what conditions are in your family? Is anyone in your family sick? Is anyone in your family dead? What are they sick of? What did they die of? And then again, ask, is there anything else? So keep going to exhaustion and finding out, what other conditions might be in them or in their extended family. And that's their past medical history, including their extended family. And then we flip over into their social history. And we'll transfer that over to you. You can go with the social history. All yours.
And this is a bit like writing an autobiography about themselves, isn't it?
It's kind of like, yeah. Tell me your story.
Chapters. Yeah, what's your story in 9 chapters? So
tell me the chapters.
That's it. The first bang we were born. So whether that was normal, were they preemie? Have they had problems since then? Where were they born? Are they? Did they have good healthcare when they were growing up? Is possibly relevant there too. We get an education after that. We get born, we go to school, we get a job at that point. We might find something really interesting with the background there. People who've been in some kind of trades industry that could have had the potential to lead to lung problems.
Sure.
Any kind of sort of environment where there could have been a known history of carcinogenic agents or anything like that. Then we start dating, don't we? After we get a job, we've got some money, so we start going out. So there's a bit of social going, and not, with that goes, any kind of potentially even anxiety or, things that are starting to come out as people get older and we get married at that point too. We have all these little life upheavals, then we have our children and then the next thing we do, the children drive us to to drink and smoke
take drugs.
That's it. That's our next stage. And we need to go on holiday or retire at that stage. And sometimes then we get sick and we end up going to hospital. So that's kind of our autobiography, our social history. And all of that's actually really important. And I know that, for me, when we go to a lot of elderly patients and asking these background questions about social history becomes so vitally important because, we end up taking into the hospital and sometimes we find along the way that, they've been home alone and they haven't been coping, they're not eating and you look in the kitchen, there's no food and, they might have one person that comes to clean the house, but really what they actually need is a falls assessment, and they actually need a geriatrician to go through their drugs. And they've been on the same medications for, 10 years and haven't had a review. So all of this social history background, whether you realize you're doing it or not, this is the stuff that's, vitally important to actually, it may not present as the primary problem that day, but might actually be the reason that they're now falling over or now that they're not being able to self-care or now that they've got heart problems because they're not being managed properly in all of this other social stuff that's around the patient itself. So even undiagnosed mental health problems in the elderly and, elderly abuse, you name it, we've got so many problems going on out there that we're just scraping the surface of trying to understand these days. And that's when this social history becomes so vitally important.
Okay.
All right. So
Chapter 1, we're born. Chapter 2, we get an education. Chapter 3, we get a job. Chapter 4, we go dating. Chapter 5, we get married. Chapter 6, we have kids. Chapter 7, they drive us to drugs.
Yeah.
Chapter 8, we retire or take a holiday. And Chapter 9, we end up sick and going to the hospital. Ask through each of those stages. Perfect.
Yeah, that's right. So it's a life story when you think about it. So what you're trying to find out is the life story of the patient and see if there's anything in there that can be cues to what's going on today for them.
Right. Okay.
Or even undiagnosed things that, need to be addressed. Yeah.
It's also a really good process to go through because the average emerge physician spends about 5 minutes talking to a patient, and we might be in the back of the ambulance with them for half an hour. So sometimes you don't know what to talk about, and asking about their life story is really helpful, especially with people who like to talk and want to. But when we spend 20 minutes asking them about their social history, there may be nothing of relevance in there medically for this particular condition, but there may be one or two nuggets that are really important. They just got back from a TB-infested country. You wouldn't have asked that if you didn't ask about holidays and, stuff like that. They may be a transgender patient that we didn't think to ask about, and sort of the archetypical 25-year-old male with a beard who has abdominal pain, but it's an ectopic pregnancy.
Oh, gosh, yeah, that'd be confusing.
So those sorts of things, by getting more of a social history, it's nice for the patient, and it can identify some red flags for us that we might not have realized were there.
Yeah, absolutely.
Okay, so identify the patient, chief complaint, incident history with the NOPQRSTU. I see H is their medical history, and there's them and their family, and then their social history.
Social.
And then A, so ICIHAD, A is for allergies. And allergies is actually fairly simple. We just ask them if they have any allergies. And the different types of allergies that people normally have, there's 4. There's environmental allergies like hay fever. There's chemical allergies. There's food allergies, shellfish or things like that. And there are drug allergies. So sulfa drugs, for example, is a really common example. And I have a bit of a mental image because I can't remember things unless I turn it into mental imagery. So imagine that there's someone walking across the lawn with their bare feet, and they have a plastic cooler. In Australia, you call those an esky. So they grab the chemically plastic cooler, and they take out a peanut, and then they take out a pill. And that's what's in there. Mm-hmm. So the feet on the grass is environmental allergies. Touching the plastic of the cooler is a chemical allergy. Taking out the peanut is the food, and taking out the pill is the chemical allergy. And just
that's good.
Yeah, it just helps me because I remember those 4 things. And if I just try to remember without a mnemonic or memory theater or something, I can't remember it. So it's also important in allergies to be asking, just like we did in the medical history, is there anything else? And just like we will in drugs, anything else? So yes, I'm allergic to peanuts. Okay. Anything else? No, that's it. All right, then I can stop. And then before you move on from allergies, it's really important to ask, what is the allergic reaction that you have? Because I've had patients who say, oh, I'm allergic to morphine. It makes me throw up. Well, yeah, morphine does that. I mean, that's a side effect of the drug. I'm allergic to nitroglycerin or GTN because it makes me lightheaded. Yeah, that's not an allergy. What we're looking for when we're asking about allergies is the skin reaction, the bronchospasm, the hypotension, the agitation, like signs leading more towards anaphylaxis. That's the allergy that we worry about. So IC, history, allergies, and then over to you with drugs.
Drugs. Okay, so again, like allergies, there's sort of different categories when it comes to drugs. So, and we often, we get handed the pill packet or the blister pack, and it's all the drugs. But, when you go to Nana's cupboard, she's also got all these other things in there that she takes because she's feeling a little bit unwell. So she's got all these other alternative things that she might take in there too. So when we're talking about the drugs of the patient, we are looking at all kinds of stuff. We're looking at complementary or alternative. So they might have breakthrough medication if they're a palliative care patient. That might not be the standard set, but it might be something in addition to what they've got as their base set of meds.
Yeah, St. John's wort.
Yeah, it's a classic
St. John's wort is the one because it interferes with a lot of conventional medications. So
and they're meant to stop taking it. They're meant to stop taking St. John's wort when they start on, all of the other sort of antipsychotic or anti-anxiety drugs.
Right.
But quite a few patients keep on taking St. John's wort because they think, well, what hurt can it be? Because it's, it's a natural drug, but actually it does interfere with SSRI or serotonin, I think, in the brain as well. So are they on any complementary things? And also the problem with some of the complementary stuff is that it actually inhibits the uptake of other drugs as well.
Right.
So, for instance, the blood thinners and stuff like that, they can take complementary medicine and it actually either inhibits it or makes it work, even more so than what it should. So make sure you find out if they're taking their own plus extras. So whether it's over the counter or whether it's something, they borrowed off their husband.
Yeah.
I've been to, sometimes you go to, they're like, I'm just taking a couple of his ones that he takes when he's feeling a bit like this.
You know what? I've got a good story for you. There was a patient we had years ago. She was a young woman, incredibly fit. She was like a bodybuilder and she was all natural bodybuilder and she was bratty at 30 and we couldn't figure out what it was. And we brought her in to the hospital. They weren't quite sure, brought her up to the Emerge, and I remember going up to the ICU, and we went up later to the ICU and said, what's going on with this patient? And this old anesthetist that I knew came over and said, well, let me see your 12 lead. He looked at the 12 lead, he said, all natural, eh? Does she take any supplements? And she said, yeah. And I said, I bet you any money if you take a look at her supplements, there's foxglove in her body, all natural bodybuilding supplement, because it's a cardiotonic. And it had made her dig toxic.
No way.
Yeah. And he saw it on the 12 and he's like, that's a dig sign there. So, so any of these natural remedies, if you can grab them and take them and bring them in, you don't know what's in there.
Yeah. Good lesson learned in that one. You wouldn't think that foxglove had been in that, but that's really.
Yeah.
So
it was like, wow.
Scooped out segments and stuff like that. Yeah.
All the dig signs.
That's really cool. Yeah. Okay. So the other thing also on the back of that is the illicit drugs, isn't it? So, so anything that you can think of that they might be taking recreationally or, like they might have had the one off or whatever, it doesn't really matter. You need to sort of get to the bottom of some of that stuff and always be aware that sometimes they don't want to disclose that information too. So you've got to kind of approach that stuff in a non-threatening manner and hopefully they'll open up to you and you can actually find out what's really going on because especially if mum and dad are in the room or friends or boyfriend or anything police, like that.
If the police
you might find out that, well, even things like the slimming pills, what are they?
Well, there's caffeine.
Duramind. Yeah, like just a whole heap of that stuff. They may not want to tell people that they're taking,
Yeah.
but they actually, it's interfering with especially cardiac signs. Some of that stuff is just awful.
Mm-hmm.
So, get to the bottom of the illicit drugs. And again, anything else that you're putting in your body, tell us about it. Whether they think it's relevant or not, let you make that decision, because sometimes they just don't realize that it may actually be affecting or contributing to what they're presenting with today.
Right.
So the anything else is, again, really important.
Okay. So
yep.
Complementary, over the counter, like Panadol,
Yes.
Tylenol, aspirin type stuff.
Yep.
Prescription. And are they
and
taking the prescription? And then illicit drugs, and then anything else.
Yeah, correct.
Good. So that's our drugs. So we've done ICI, HAD, the D being drugs. So ICI had, vitals. Now, we've come up with a bit of a fun thing. This is in the paper of the secondary survey. But when I am teaching vital signs to the students, I ask them, how many vital signs are there? And usually they say 3 or 4, respiratory rate, heart rate, and then we kind of go from there. And when we sat down and thought about it for the paper, we actually realized there are 12 that we regularly take on just about every patient. And I've come up with a way, again, I need memory theater or mnemonics or initialisms or something to remember. And I find that my students respond to that really well. So I like teaching that way because that's the only way I can remember it. And they seem to like learning that way. So here's a cool thing, a way to remember the 12 vital signs. So there's 6 above the neck and 6 below the neck. And on the head, there's 6. There's 3 above the eyes and 3 below the eyes. So we break it in half. So we go above the eyes, below the eyes, and then 3 under the t-shirt, and then 3 on the end of your arm. So I'll go through them. And I actually do a bit of a choreography with the students. I tell them, put your hand flat on your head, and then I want you to touch your temples with your thumb and your fingers, and then I want you to put the back of your hand on your forehead. If you're following along in the podcast, you can do this, but not if you're driving, okay? Don't become a patient. So one hand flat on the top of your head reminds you to ask about their overall levels of awareness, their GCS or Glasgow Coma Scale, or their alert, verbal, pain, unresponsive. What's their levels of awareness? And then the fingers touching the temples is pain. If they're having any pain, what sort of pain are they having? And then the hand touching the back of their forehead is assessing their skin and finding out the condition of their skin, pink, warm, dry, or what. So the 3 above the eyes are levels of awareness, pain, and skin condition. Then we go below the eyes for the next 3. We go into the nose, and I usually point with 2 fingers. So pointing into the nose, that's the end-tidal CO2 reminder. And then, I skipped one, sorry. Below the eyes, we go to pupils. We check the pupils. Then we go to end-tidal CO2. Then we go into the ears and take their temperature. So levels of awareness, pain, skin, pupils, end-tidal CO2, and temperature. And then we go down to the t-shirt, and I take 2 fingers and I put them on either side and point to both lungs, and I say we assess the respiratory. So you might be listening to the lungs, but definitely you're getting a respiratory rate. How are they breathing? And then I switch one finger, top right shoulder, the other one left flank, and that's my ECG, because I consider an ECG a vital sign. We take that on anybody
It is.
Yeah. So we take the ECG and then put the hand around my bicep, and that's a reminder of blood pressure. So the 3 under the t-shirt are respiratory, ECG, and blood pressure. And then we get down to the end of the hand, and we take the radial pulse. That's our 9th, or 10th. And then we take a blood sugar by tipping the end of the finger, and then we put an SpO2 over. So we've got 12 vital signs in order from head to toe, or head to hand. And if you're practicing them, practice them from the top down and then from the down to the top, and get comfortable with those so that when you're doing scenarios and when you're actively involved, if you've got that memorized, it just offloads that whole cognitive load. And if your partner says something like, what vitals do you want me to take? Here they are. And you can just go head down and get those vital signs. So ICI had vitals, and then next we go to
assessment.
That's right, physical exam. Classically poorly done by paramedics and students.
Oh, yeah. And this also coincides with the head to toes. Well, it's the head to toes in a sense. We talk about the head, starting from the head and working down. And coincidentally, we thought this would actually work really good in a video, this actual topic, as a separate entity itself. So we have actually made a video, a lovely video, of performing this assessment as a part of this ICI had. We've got this component of the A component we're actually doing as a video. So the link to that will be on our site, the paramedicine.com site, and it's also on our YouTube as well. So be sure to check out that and watch that in conjunction to me talking about it. Because with this particular, we think that this is a visual presentation of the actual assessment of the parts of the body itself. And, it always works better visually than actually sort of trying to describe it, what we're doing. Although we are pretty good at describing things. But
I like to think so.
Yeah. Yeah, absolutely. So, but, later you'll learn to assess a patient by their anatomical system. So in a part of this, we're just talking about the head to toes component. But each one of these elements has its own sort of thing that goes with it. So a neurological exam, a respiratory exam, an abdominal assessment. All of those are lessons in themselves and are a part of something else much bigger than probably the presentation we're doing today.
And those will be future podcasts, right? We'll get to those. We'll do the neuro exam. We'll do the cardiac. We'll do the trauma.
Yeah. And specifically relating to us as paramedics and how we go about assessing those in our environments and making it relevant for you about the things that we should be looking for and the tools that we've got to actually perform these in our care and to the best level that we can. So when we're going through these elements of the assessment, we're thinking, again, from the top down. That's always the best way of looking at it. And when we're looking at our head, when we're looking at the patient's head, we're obviously, looking for anything obvious that we can see, for any lesions. We're looking at the various elements of the face and also, around the sides of the head. So the pupils, the ears, the eyes, nose, mouth, etc. All of those are elements that need actually exploring for anything, trauma, discharge, bruising, etc. When we work our way down into the neck, there's actually structures in there that we really need to be mindful of. So the trachea, is it midline? The JVD, the jugular veins, are they distended? Are they retracted? Are they flat? Is the patient dehydrated or fluid overloaded? Lymph nodes are in here too. So at this point here, you'd be palpating and asking if they had a sore throat or had been unwell lately. It goes hand in hand with your infection signs that you were talking about previously. Coming down into the chest. Now, I don't know about you, Mark, but, we always ask our paramedic students to palpate the chest.
Absolutely.
And ask the patient to take a breath, you know. So depending on whether they're, major trauma or, these are the things that we'll talk about later in the video. You can go into more depth about that stuff, but what's appropriate to explore at the time on this patient.
Right.
So it may be as simple as, they've been in an accident, but we just want a quick look at this stage, and you might just say, can you take a deep breath for me? Do you feel any pain? You might be feeling the chest rise and fall, the expansion of the chest at that point. And then, of course, after you're exposing, you'd be looking at things like, whether it's rising and falling normally, does the skin look normal, is there any signs of discoloration, auscultating it at that point to listen over the places of the chest.
Subcutaneous emphysema, shingles, there's all sorts of paradoxical chest wall motion. You have to look. You have to look at the patient's chest.
Absolutely. Yeah. Expose is, there's nothing worse than getting to hospital if you haven't exposed the patient and they start cutting off clothes because you didn't bother and then getting caught out.
Yeah.
Nothing worse that you do not want to be one of those paramedics.
Did you see that bone before? Did you realize that was sticking out of their chest? Oh, I missed that. Oops.
Can I tell you a funny story?
Yeah, go.
We made the mistake of picking up from a first aid crew. They'd wrapped up the calf muscle, and everyone just goes, calf, whatever kind of thing. This guy had kicked a door, was a plate glass door, and he was actually a really attractive, good-looking guy, and we're like, and he's all fine. He's sitting there all good, and he'd been out on the night on the town, got a bit drunk and a bit frivolous and kicked the door, cut his leg, first aid crew. bandaged it up. And so he was a packaged patient when we got there, and he looked pretty good, quite nice looking, hop in the truck, all good. I get the handover from the crew and they're like, oh, yeah, it's just a bit of a cut on the leg. Yeah, no, it's all good. We've all wrapped it up. It's all sweet, ready to go kind of thing. We didn't unwrap it, right? We didn't look. We get him into the hospital. They unwrap it and I'm like, giving my hand over. Yeah, it's just, kick the door and, the first aid crew's got it under control, not a lot of bleeding or anything. It's, all good, just a bit of a laceration kind of thing.
Yeah.
She unwraps it and the calf, the muscle was cut on both sides and it just hangs off.
Oh, no.
And I was like...
That's a little worse than I thought.
There's a little bit of an underestimation of how bad it was. Anyway, moral of the story. Expose.
Yes. I got a quick one for you too, because I got caught the same way. It happens to the veterans. We had a patient. He was relatively fine. He had some other complaint. I forget what it was, but I did a quick listen to his lungs over the back, over the shirt. And I reported as we came in, equal air entry, clear bilaterally, apices to bases.
I can already see where this is
what's going on. So the nurses took off his shirt and there's this big scar on his back. And they said, what's this? He said, oh, I had my right lung removed. Oh, well, it sounded pretty normal to me.
It's one of those things that it's a rookie thing, but it gets us.
It totally
veterans, is. Like going for, was it a right hand spanner or a striped paintbrush? It's like, listen to that chest and, what do you hear?
Yeah.
Get them to listen to the patient. What do you hear? Oh, yeah, I think it's pretty equal. And it's actually, well, they've got a history of having a lung removed.
That's right. I was caught.
I think it's happened to me. Yeah, I think somebody else framed me and I got into the same position. So, yes, major learning curve here. Always expose. Okay,
visualize.
Expose and visualize, absolutely. Let's move on to the abdo. So we've started at the head and we're moving our way down. The abdo, a lot of us learn either quadrants or the 9 areas of and you need to know what's also underneath that. So when you're palpating it and you're feeling it, you've actually got an idea of what's under there that could be wrong.
Right. One
of my peeves is that we quite often go to, I'll assist people who are treating somebody and they'll be like, oh, it's in the abdo. We don't know, it's just an abdo pain. And they kind of get a bit stuck. Yeah. And I think half of that is because they don't know what's actually in there about where it is, where the pain is, and then linking that back to patho about what could be wrong relating to that part of the abdomen. So, it's a big point here is to actually go and learn the symptoms and learn, absolutely. Yeah. Can't stress that, especially with new paramedics who are just learning it. It's one of those big steps. Don't get stuck into that, it's just somewhere in there, abdo, who knows kind of thing. Actually learn about that. And things to do with that, fluid in the abdo, ascites is a really interesting one that we see in our heart failure patients as they get older and they start collecting fluid. It's not just in the peripheries, they actually collect in the abdomen. Mm-hmm. So looking at abdodistension and looking and asking about those kind of things, has your abdomen swollen up over the last couple of weeks? Is it to do with fluid? Is it to do with, unpassed bowel motions and they've actually got a rock hard abdomen because they haven't been, the bowels aren't working properly. And, there's so many things going on in there that you really need to understand the location of things and palpate them and feel them and know what is normal for that patient as well. So pulsating masses also go with that. You've got signs that you need to probably learn about. So Murphy's sign, but also Gray-Turner's sign. And what's the other one where they get around the flank? So you get the bruising and redness around the umbilical area and they get bruising around the flank. It's to do with acute pancreatitis and inflammation, bleeding and swelling. So there's signs that we see that are related. So not just the Kerr sign up into the shoulder, but also Murphy's and Gray-Turner's signs as well.
Right.
So moving on from the abdo, moving down into the pelvis. Obviously, if they've had trauma, then, you would go through your various ways that you've been taught about feeling for pelvic injury. Now, back in the day when I was taught, we got taught to spring the pelvis. Now, that went out of vogue.
Yeah. Is it broken? Let me rock it around and try and, make it worse.
I can get nothing worse now.
No, go by mechanism of injury. If you think it's broken, just splint it. Yeah.
And the pelvic fractures that I've had, the ones not where we suspected it, like we actually found out later that they really did have a pelvic injuries, those patients, there's no way on earth that they would have allowed me to rock their pelvis or spring it.
Yeah.
Because it's painful. That was actually one of the signs that I found out later was a really good indicator.
Right.
You know, if they don't allow you to do that, then it's probably a really good sign that they've actually got a pelvic fracture or a pelvic injury.
Yeah.
So has there been signs of incontinence, priapism, spinal injuries? You know, you've got to think of all of those things that could be wrong in that area. Again, depending on whether it's trauma or not, you've got to move on to the back at this point. Don't ever forget back. And we could probably talk 100 stories about being caught out because me too.
Yep.
And, you know, making sure that the back has been properly examined, you know, and you may need to make that when you move the patient, you know, from the original position onto a scoop stretcher or onto the bed. At that point, you might need to check the back if you're really worried about spinal assessment. But at some point, you have to check that back.
You need to see it. Yep.
Absolutely, and properly. Do not overlook it. And then going on to the limbs, so testing for motor function, sensation, warmth, tender, you know, anything that could be abnormal about colour, warmth and sensation in the peripheries, taking pulses of all of the limbs, looking at things like fingers, especially if they're respiratory patients, you might be looking for clubbing, which is where you look at the fingernails and the shape of the fingers. Yeah. But like I said, all of these little things are much better described in a video where we can actually show you doing the motions of how to palpate, how to listen properly, the motions of rolling the patient and, you know, using the right technique to actually palpate the abdomen, what you're looking for. This all goes really good with a video, which we're going to make sure that we have access for you.
I've done it in the lab with a mannequin. So I'm just basically doing a talk, teach, and touch type thing of going head to toe and explaining what they are. So that'll be up there. You can look for it on, just search for paramedicine.com on YouTube.
Yeah. So I don't forget that, you know, the secondary survey, I think a lot of people used to think that the head to toes was the secondary survey. And as you can see, it's not. The secondary survey is made up of lots of components. And this component, the actual assessment, is just one part of many of it.
Yeah.
Yeah. Okay, Mark.
Good.
Moving on.
Yeah. So we've done identify the patient, chief complaint or condition, incident history with the NOPQRSTU, ICI had, medical history, allergies and drugs, vitals, is the vital signs, the 12, assessed, the head to toe, and then treatment. And treatment is actually a fairly simple one. So when we arrive, we want to ask the patient, what treatment have they done already? Because often people will try to fix a problem themselves before they call the ambulance. I had chest pain, I drank some milk. I got cut, I rubbed butter on it. You know, whatever they did, we want to find out what they did before we arrived and what effect their attempted treatments had. Because maybe it made it better. I had a really bad headache. I took my, Panadol and I'm feeling better now. Oh, okay. Yeah. Is there anything we can do to help? So we want to find out about that. And then at this point, we're going to be thinking treatment. What treatment do I want to do? And as paramedics, usually the question we have at this point is a simple yes, no. Do they fit in any of my CPGs? Do they fit in any of my protocols or whatever we call them? They're seizing. Do I have a guideline for that? Yes, I do. They have abdominal pain, which is vague, and they're not hypotensive, and it's not really painful. Do I have a guideline for that? No, I'm going to take them to the hospital and let them get checked out, So we go through the ICI had, vitals assessed, and at that point we ask ourselves, can I treat this patient in any way? And if not, we used to have the simple joke, the next binary question is, can you walk? Because we're just basically taking you to the hospital. Now that has changed a lot recently in paramedicine with the introduction of extended care paramedicine, community paramedicine, whatever you want to call it, where a lot of paramedics are trained to a very high level to assess people with low acuity, we call them Miami, minor injuries and minor illness. So assessing the Miami patient as opposed to the resuscitation that we used to focus on when I was a kid, right? Sure. So there's that whole element of Miami, and that extends a lot of our clinical practice guidelines of what we can work on now. But whatever your training, whatever your scope and standards of practice are, ask yourself at this point, can I treat the patient? Do I have something in my bag of tricks that will allow me to help them? I implement the treatment, and then critically, I monitor the results of the treatment. So I see what's happened. They're having chest pain. They're systolic of 160. I gave them 1 spray of nitroglycerin, and now they're a systolic of 90. Whoa. Okay, I better not do that again, right? So we're aware of the treatment that we've done, and then we think a little bit to ourselves of what further treatment do they need? And that's a good prompt for us of, maybe this is a complex neuro, and they need to go to a neuro. Maybe it's a trauma, and they need to go to a trauma center. Maybe it's maybe they need a catheter because they're having chest pain, and we think it's acute coronary syndrome. So what treatment do they need, and where can they best get that? And that helps guide our care from that point on.
Sure. Yeah.
So we've done identify the patient, chief complaint, incident history, medical history, allergies, drugs, vitals, physical assessment, and then we've started to think about treatment. That's the ICI had, vitals assessed and treated. So it's a really useful guide. As I said sort of in the beginning of this, it's a really useful guide when you ask yourself, have I done everything? And it's a good review for you to have a checklist of what, quote, air quotes, everything is. But it's also got another function, which is really useful.
And that is a handover. So, we talked about this actually last week when we were doing the primary survey, and in the sense that they're similar in the sense that it helps you remember everything that you need to get done. And the primary survey, the one that we talked about last week in our podcast, was about reflecting over those really important, vital, critical things and having an order of priority and your approach to the patient to make sure that you have the best outcome for that patient and your time is spent wisely at the beginning. Now, this part is the last part of this presentation. We're going to talk about using the ICI had vitals assessed and treated as a handover tool. So once we've gone through this and we're pretty sure that we've been comprehensive with this patient, you can use this format, the ICI had vitals assessed and treated, as a format for actually presenting the patient to the staff at the hospital. So what we've decided to do is we've got a couple of cases that we've put together, and we're going to use the tool in our means of being able to hand over to the hospital. So the first one I've got here is a medical scenario, and I'm just going to talk it like a narrative, okay? So watch out for the ICI had vitals assessed and treated in my letters that I'm giving. Yeah? Okay. Hi. This is Jane Everstone. She's a 23-year-old female. C. I found her atraumatic, tripoding at home in her kitchen with moderate shortness of breath. I. Apparently, she normally takes Ventolin, PRN, about 2 to 3 times a month, but she ran out about a week ago and started developing shortness of breath at home today while baking. That's what cooking does. H. Other than mild asthma, she has no other medical history. She's been hospitalised twice with acute asthma over the past 8 years, but never intubated and never admitted. So it's never been to ICU. A. She reports no allergies. D. Other than Ventolin, she takes no other meds, and she's a social smoker. Okay, don't forget the illicit stuff there. V. She was tachypneic, tachycardic, and anxious on our arrival. The ECG shows a sinus tach at 110. A. On exam, she has accessory muscle use, global and expiratory wheezes, pink skin, 4 to 5 word dyspnea, sitting in a tripod position, room air, so sats on room air, 91%, end tidal CO2 of 50, with a bronchospastic waveform. So she's got a ratio of about 1 to 3. The JVD to the angle of the jaw, while high Fowler's was okay. No abnormal respiratory pattern, no signs of attention pneumo. T, this is T, the last one. She had no treatment prior to our arrival. We've given her 10 of Ventolin and 500 of Atrovent with oxygen. We've got a 20 gauge in her right AC with TKPO fluids going. Her wheezes have resolved to a very subtle end expiratory. SATs are sitting at around 98%. CO2 is now 38 with normal waveform, and she says she's breathing easily now. Does anyone have any questions for us?
Beautiful.
So you can see how that's provided a very comprehensive handover to the staff. The trick is getting them to listen to you.
That's right. Well, the trick to that is to be concise, to be organized, to follow a format. When you start waffling, when you start hmming and hawing, that's when you start to lose them. So you got to go in, you got about a minute at most, 30 to 60 seconds. You got to hit the high points and just get it across. And then always ask, does anyone have any questions?
Yeah. And that becomes even more important in the trauma scenario, which, Mark, you can do now. But this might be, you might have more of an audience even. So, with the high trauma jobs, you might end up having, a doctor, anaesthetist, and a couple other people in the room, and resus is fully going. There could be, 7 staff happening. Yeah.
Okay, so I'm going to walk in. I won't do the ICI had because you've introduced that now so people can understand. Yeah. As you're listening, see if you can hear where I switch. Okay?
Good.
And this is me walking into a trauma room. Well, it's not a big trauma, it's a small one, but, walking into a nurse and a doctor.
Yeah.
So this is Brian Fraser. He's a 42-year-old male found resting on a chair at a construction site where he's a tradesperson with the site first aider on scene. He's got a fairly deep, ragged laceration on his right lateral calf from some exposed sharp metal at the work site. Apparently, he stumbled on uneven ground into this exposed metal. He didn't fall, he didn't hit his head, no loss of consciousness, no syncope. It's isolated trauma. He's got no past medical history. He's not sure of his last tetanus shot. No drug allergies. He takes no medications. He's a pack-a-day smoker. Vitals are all fine. On physical exam, he's got this 4 to 5 centimeter horizontal gash on his right calf, and he says the metal went fairly deep. We irrigated the scene. We've got it bandaged and it's holding. It was initially a well-controlled venous bleed. We gave him some methoxy for pain as we cleaned it, which helped. It looks like a pretty dirty cut, though. Does anyone have any questions for us? Okay, so that's our summary of what we're calling the secondary survey. ICI had, vital signs assessed and treated. We've gone through it in detail now. Hopefully that'll help you organize your call. And again, as always, thanks for listening to the podcast.
And make sure you come and visit us on the paramedicine.com website.
We are setting up our email. You can reach us at inquiries@paramedicine.com.
Also, you can follow us on Twitter and paramedicine.com as well.
And if you go onto iTunes and search for the paramedicine.com podcast, specifically on iTunes, if you leave a rating, that really bumps the podcast up in popularity and it lets people know more about it. So that's a really wonderful, free, easy way to help us get this podcast spread out a little bit. So come and visit us and give us a rating.
Yeah, please do. Don't forget Facebook too. We're on Facebook.
And YouTube. So just search for paramedicine.com and you'll see us there.
And we'll be back next week.
That is it for this episode. Thanks for joining us.
Remember to keep on studying.
Keep on caring.
And keep safe out there.